get started in like 30 seconds. Good morning, good morning, good morning. I'm Jordan, PGY2. I'm going to be presenting on disaster and mass casualty incident triage. And we've learned about START, the triage system, and you'll see it, you'll recognize it when you see it. But I wanted to go beyond START, talk about some alternatives, and have us kind of have a critical discussion about it. So my objectives, we're going to define mass casualty incidents and define triage. We're going to briefly compare START to another more widely accepted but still questionable system called SALT. And then we're going to apply some triage systems to a disaster simulation. We're going to present some alternative disaster triage systems, and then we'll talk about a contemporary disaster response. So disaster or mass casualty incident is defined by World Health as normal conditions of existence, or when normal conditions of existence are disrupted and the level of suffering exceeds the capacity of the hazard-affected community to respond to it. New York's EMS that defines mass casualty incident as any sudden event or situation that has produced, is believed to produce, or experience indicates that this may produce a minimum of 5 patients. And then triage is a French-derived word meaning to sort. And NATO's Emergency War Surgery Handbook defines triage as a dynamic process of sorting casualties, basically utilitarianism. I won't go through the whole definition. So, you know, mass casualty could range as a wide range of situations, one being a bus crash. Does anybody know what this picture is from? Boston Marathon, exactly. That's another example. And then how about Vegas? Vegas, exactly. We'll talk about Vegas a little bit more later on in the slide. But START triage, we know that we've gone through this raw disaster training. And so initially, your first breakpoint in the flowchart is patients who are walking. The walking wounded, they are green, and they're going to be treated as requiring eventual treatment. Then there's yellow patients whose lives are not in immediate danger but require urgent care. And immediate danger being defined as that golden hour that we get from shock trauma. So these patients can be treated after the golden hour but shortly after. Red being patients whose lives are in immediate danger or require immediate treatment in this golden hour. And then finally black are patients who are dead or such extensive injuries that they cannot be saved with the resources available. So first breakpoint, walking wounded are green immediately. After that, you can go, RPM is a quick mnemonic to help you remember how you're going to evaluate the rest of the patients who are not walking. So first being respirations, P being perfusion, M mental status. So patients who are apneic despite repositioning are going to be, didn't show up, but are going to be black. So these patients are dead or such extensive injuries that resources cannot be used to help save them. So this not being a rhetorical question, I'm curious, what do you guys take repositioning an airway to mean? And jaw thrust, any other repositioning techniques? Maybe put them on their side. Right, so kind of, you know, vague but small, minimal interventions. And so we are saying in 2018, in the United States of America, if you do a jaw thrust and you can't get an airway, that patient's dead. You don't have the resources available to intervene in this, to save this person's life. So that's something to consider. Next, if their respiratory rate is greater than 30, if they have absent radial pulses, or if they're not able to obey commands. Once again, this kind of RPM helping you remember these 3 evaluations of the patient. That makes them red, so they require immediate treatment. So raise your hand if you trust respiratory rate from vitals or from triage. I don't feel comfortable with it. I'm sure, just looking at most patients, even in the 10 seconds that I might be paying attention to the respiratory rate, it may vary from time to time. And everybody kind of calculates this differently. So the respiratory rate being above 30 is going to determine whether a patient needs golden hour immediate treatment or whether that you can put them off for a whole hour. From triage, from vitals, just respiratory rate. And then if the respiratory rate is less than 30, if they do have a radial pulse, and if they are obeying commands, then they become yellow, and that requires urgent care.
Don't forget, if you have a respiratory rate of 2, based on start triage, you're putting them in yellow. Not good.
Right. So they don't account for decreased respirations, agonal breaths. Start triage was developed in 1983. It was a way to kind of standardize responding to a mass casualty incident for between Hoag Hospital, WAG, I don't know how to pronounce it, and the Newport Beach Fire Department. And they worked together, came up with the start triage, but once again, 1983. And then kind of some other things to consider. You have walking wounded, but what about a walking wounded patient with a blast injury? Would they not necessarily be maybe yellow, if not red, depending on their status? Okay, so this is not the formalized flow chart, because the formalized start triage is vertically oriented, and you couldn't see it on the page. So this is kind of just, but it looks something similar to this. And so initially, if you're walking wounded, you're minor, you're green. You get a green tag, and you are treated later, and maybe a volunteer to take your blood pressure. Then respirations is the first breaking point, kind of like we talked about. And if you position the airway and you get no respirations, in 2018 in Brooklyn, they're dead. You're doing nothing for them. So let's go through a couple examples. So this doesn't need to be perfect. If you consider yourself in the back left, then please just look at the top left patient, back right, top right, and then up front, left, right, left, right. Okay, if you are in the back left, please look at the patient in the patient in the top left, back right, patient in the top right, front left.
Mine up to your
My right. The patient's right. So okay, so just take 60 seconds. Read your patient. It's okay if you've got another patient. And try to decide how you would triage them based on the start triage. Take about 20 more seconds. All right, let's bring it back. So, back lefter, anybody who has a 34-year-old woman, anybody want to take a shot at how you would triage this patient? Dr. Kendall, maybe? I can cold call you. Red. So, who has met a POD 34-year-old man or woman with respirations of 32 because they were uncomfortable or tired of waiting 6 hours? Or smoking K2, right? So we're going to triage the K2 patients with a red triage tag, and they're going to get the highest priority, and they're going to get immediate treatment just for having respirations of 32 with no other findings. And although you may be saying to yourself, oh no, I would do something different, I would have more nuance in my triage, this is a mass casualty incident, a lot is happening, and most people are just trying to stick to this formula so that way they can triage patients quickly. You gave them a formula, people are going to follow it. What about back right? I'm going to teach you why two people. 45-year-old male? Anybody?
So he's responding to commands, he has a radial pulse, his respiratory rate is less than 30, so he's a yellow.
So he's a yellow.
Yeah, you know.
Yeah, because the blood pressure is not in the start triage, correct? However, so the 34-year-old woman with respiratory rate of 32 gets seen immediately, whereas the patient with a heart rate of 135, blood pressure crashing, but is still able to, because they're able to open their eyes and respond to commands and they have a radial pulse, you're telling them to go wait with the yellow tag. Front left. 86-year-old male sitting on the ground. His eyes are open, but he cannot answer or follow directions. Basically, can't follow commands. How do we triage this guy? I hear a whole bunch of red. How many people have had Pod A patient, demented 86-year-old who cannot respond to your follow? So this guy also gets seen before our 45-year-old male. And then bottom right.
Dead.
Black, dead. So 42-year-old woman, no obvious injury, but without a carotid pulse in 2018 is tagged as dead. There's nothing that we're going to do for them. Based on start triage. So take one more look, but I'll move on. So there are other options, and the first one that you might see and the one that's going to be compared to start with many head-to-head trials are SALT. SALT is sort assessed life-saving interventions, treatment and or transport. So this was created because there was a need for cross-jurisdictional standard that was effective and evidence-based, and START was a little antiquated. This was endorsed by ACEP. SORT also uses the walking wounded and puts a green tag on patients who are walking wounded. But then after that, it's just a simple mental status examination. If they're not able to obey commands, then they get sorted differently. And then after you make that assessment, you do life-saving interventions, and these include going through your ABCs the way you would in any resus. However, there are no definitive airways that should be used, and central lines are questionable. In addition, there's auto-injector antibodies and some antitoxins that would be relevant for a bioterrorism situation. And then after that, you will further assess the patient. Say, are they breathing spontaneously now? Has the hemorrhage been controlled with your tourniquet or whatever method? Are they still in respiratory distress? And is there now a peripheral pulse? So here's SALT. Once again, vertically oriented, kind of hard to see. But life-saving interventions is kind of in this area, and then you reassess the patient, and then you will tag them. So these are rhetorical questions. Just think about them. But how is this different from START? Which would you imagine is easier to communicate? Which one do you think would be more? Would you expect to be more accurate? Which one might under triage or even over triage more? So some head-to-head trials. I just kind of pulled some comments from the trials, but. For example, when they looked at START versus SALT, one trial said that the START methodology yielded a higher rate of under triage compared to SALT classification. Another said that the SALT triage system was overall more accurate, especially when describing delayed and immediate care. We saw that START was 8 seconds faster in another study when assigning triage patients. But for the most part, most said that they're easy to use, but often not very accurate. And it's a great anchor for healthcare workers, but not great for patients in true triage. I want to talk quickly about under triage and over triage. So under triage is failure to identify a critically ill patient. So these are patients who are very sick, maybe are crashing, hypotensive, tachycardic patient who does not get the appropriate resources allocated to them, whereas over triage is when you allocate unnecessary resources to some of the non-critically ill. And so there was one study that was looking specifically at how New York handled the 9/11 crisis, and what they saw is that the more they looked at different hospitals who were accepting patients, and the more that they saw over triage, maybe at a comprehensive center like Bellevue, you see higher mortality. So, when you think about it, this is kind of like a seesaw. There's a balance. You don't want to over triage, you don't want to under triage. You want to find something that is as accurate as possible. So, some alternative disaster triage systems. We have New York EMS has a modified START triage system, and we can pass out. Pass this out. My next slide will be relevant. But New York EMS has a modified START triage system, and they have triage tags. And what I'm passing around wasn't supposed to double-sided. Sorry, there's not as many as I'd like. But this is an example of a tag, and it would have serrated edges. You'd be able to pull it off, tag a patient, put it around their neck, and then send them to the hospital. Pre-hospital care, EMS would tag these patients ideally, so that by the time you saw them, based on your standard, you would know what level of triage they would be. Or you could also tag them at the hospital. You have FDNY has customized triage tags, and they include an orange category between yellow and red. So orange catches all patients with chest trauma, respiratory distress, stridor, increased work of breathing, head and chest trauma. There's a jumpstart triage, which is specifically for pediatric patients, humans aged 1 to 8. And then FEMA has a CERT triage, Community Emergency Response Team. And some of these I do want to be able to, I can send out an email and you can take a look at them, but the point is that there are many different triage systems, much more nuanced than START, much more catered to the needs of the community. CDC has field triage guidelines and criteria. And then there's secondary triage systems. There's SAVE triage, there's triage sort, there's something called SIV, which are secondary triage tools to help you reevaluate. So this is kind of just for those who don't get a chance. A tag may look like this, and you will, more immediate, delayed, minor. And once again, FDNY has an orange category to provide a little more nuance into the triage.
Also, the orange is for pediatrics too, because the pediatrics will be different, so the orange includes pediatrics. So New York City's the only one, I think LA is adopted it too, they're the only ones that are looking at it. So if you're 25% of the patients you're going to see are pediatric patients, you have to triage with them. So that's included in the New York City disclosure that you're getting at the end of that.
Knowing that we have orange tags, it's worth mentioning that we live in New York and it's specific to us. So, I kind of wanted to end this talk specifically talking about the Las Vegas mass shooting, one of the worst mass shootings in U.S. history, if not, I think, the worst mass shooting. And there was a Las Vegas ED where a doctor named Kevin Menace and other people, not just Kevin Menace, ancillary staff and everybody worked together to try to absorb this high volume, high acuity situation. And Judith Tintinelli, I'm not sure if there's any relation to, there it is, okay, wrote an editorial kind of with Dr. Menace talking about how he imagined the situation. And he specifically says in the beginning that he knew Las Vegas would be vulnerable to this because there's a lot of people, often in large crowded areas, there's a lot of chaos and commotion. And so he had been thinking about this for years. And he initially starts out saying that he wanted to integrate the steps, the mindset that he put himself in when he approached a recess, any recess on the red phone rings. The way he approaches that is with pre-planning ahead, asking hard questions, figuring out solutions, mentally rehearsing a plan so that when the problem arises, you don't have to jump over any mental hurdles. So basically saying that before the patients get there, before you know their triage, before you know how many people are critical, how many are not, you prepare for this situation. And I just wanted to read very briefly some of the things that he did to prepare. So in the editorial he says, the first thing I did was tell the secretaries I needed every operating room open. I needed every scrub tech, every nurse, every perfusionist, every anesthesiologist, every surgeon. They all need to get here right away. They immediately began making phone calls. I told the trauma nurses that I needed all treatment areas completely clear. Nurses were instructed to keep an eye out for crashing patients and make sure that patients had bilateral 14 to 18 gauge IVs ready for the moment that they would be compensated. So all of this was pre-planning ahead. This was discussed with all staff together before any patient ever got to the ED. The next thing that I thought was interesting, Dr. Menace and the rest of his team designated specific areas to correspond to each MCI triage level. So there was a yellow area, there was a red area, there was a green area. So that way, that wasn't something that needed to be decided when patients arrived. So I'll read a little bit. It said, my plan was that we were going to take care of all our major recesses, red tags, in Station 1. Station 2 was going to have our orange tags, and he did use orange tags despite being in Las Vegas. And then This is not, he said, this is not in the textbook. In my mind, these orange tags were expected, patients with orange tags were expected to crump near the end of the golden hour. Station 4 was going to have yellow tags. Patients that had torso, neck, or proximal extremity shots that looked very stable and were expected to survive past the golden hour would be there. The rapid track, or I guess for us fast track, and med room would hold the green tags, staffed by 2 PAs. And the ER doctors would resus and send the resus patients to trauma 3 or 4 for the trauma surgeon to prioritize patients to the OR. Patients arrived 4 to an ambulance. He said most patients, each ambulance or car would drop off 4 patients. He said I would pull a patient and yell rapid track, station 4 or station 2 or station 1. The staff would then wheel the patients in the gurney or wheelchairs to those areas, drop them off, and come back for more. Once again, orange cards were used. Shout out to orange cards. And then still, despite all this planning, despite everything he did, there was still more nuance that he had to add into his approach. So last part that I'll read, he says, if they were crumping with a GSW to the chest, they get a diagnostic chest tube. We ran out of thoracostomy trays, so I used suture kits and scalpels. I would cut down to the ribs, pop the pleura with a needle or driver or mosquito clamp, then take some suture kit and stitch it in place. When I ran out of chest tubes, I used ET tubes as a temporary chest tube while we waited for more supplies. We didn't do any thoracotomies that night. That was valuable time we used to save the red and orange tag patients. Some were shot in the neck or shot in the chest, but they were still awake and talking to me. These went to my orange area because I knew I probably had 30 minutes before they crashed. We were in the hallway of Station 1 with the beds side by side. We were butt to butt intubating these 3 people. I need etomidate, I need sucks. Up until then, the nurses would go over to the Pyxis, put their finger on the scanner, and we would wait. Right then, I realized a flow issue. I needed the medications now. I turned to our ED pharmacist and asked for every vial of etomidate and sucks in the hospital. I told one trauma nurse that we need every unit of O-negative blood here now. The blood bank gave us every unit they had in order to increase flow through the unit. So, let me get my format in here. Doesn't look great. I don't know what happened. But I think my major take-home point is that although we have flow charts and we have endless triage systems, and most of which are worth taking a look at and worth thinking beyond start, that these situations are more like lava lamps. They change and they morph, and you have to adapt and improvise. And so think of them more like lava lamps than flow charts. Lava lamps. So yeah, here's my Thank you, Dr. Aquila. Questions?